So mitral valve disease, what is mitral valve? It's a valve between left atrium and left ventricle. It directs the flow of blood from the atrium into the left ventricle. How many cusps it has? Two cusps. The anterior leaflet and the posterior leaflet. Now, a 22-year-old primary gravida was found to have a murmur. During her antenatal assessment, the patient is completely asymptomatic. The vitals are normal. There is a tapping apex beat with loud first heart sound and normal second heart sound. There is an opening snap with a mid-diastolic rumbling murmur and a pre-systolic accentuation. So you got these findings on examination. There is loud first heart sound, second sound is normal, there is an OS, diastolic murmur, and a laced diastolic accentuation or pre-systolic accentuation. Now, how would you interpret these findings? What is the conclusion we can draw from these findings? Patient was asymptomatic. It was determined during pregnancy that she had a murmur, and the physician found this. How would you interpret this? It's an obstruction LV inflow which prevents proper filling of LV during diastole. Normal mitral valve area is 4 to 6 centimeters. If it is 2 centimeter, patient starts having symptoms. If it is 0.5 centimeter squares, it is very tight. Rheumatic carditis is the predominant cause. Prevalence is decreasing, especially in the first world because of decrease in rheumatic heart disease. Practically, mitral stenosis is rheumatic fever. Now we see this patient has sinus rhythm. LA is probably of normal size because if the LA starts increasing, you tend to have atrial fibrillation. So in sinus rhythm, it means the LA is not very, very big. First heart sound is loud, opening snap is audible. This means this is a pliable valve, not very calcified valve. Normal S2, it means patient does not have a significant pulmonary hypertension, because one of the complications of MS is patient develops pulmonary hypertension with long-standing MS. Pre-systolic accentuation again indicates sinus rhythm, because in atrial fibrillation, this pre-systolic accentuation disappears. This is because of the atrial kick at the end of the diastole. What happens in diastole? The blood starts coming into the atrium, and this rapid inflow produces that mid-diastolic murmur, and then at the end there is atrial kick. That causes further movement of blood into the left ventricle, and this is done by the atrial systole. In atrial fibrillation, this atrial systole will be absent. So the patient will not have this late diastolic murmur. So you can see from simply having this information, you can draw a lot of conclusions. Okay, what is the underlying state of the valve? Your response to the call: explain and reassure the patient to proceed with pregnancy and keep the follow-up. Because in most probably this patient is not going to have problems because of mitral stenosis. You can ask for an echo and confirm your findings. If there is anything contrary to your findings on the echo, then you can go accordingly. Now, mitral stenosis, 77 to 99% of all cases is rheumatic heart disease consequence. Infective endocarditis, because if there are big vegetations on the mitral valve, they can block the passage and cause functional MS. Similarly, tumors can produce mitral annular calcification. And then we have got a congenital condition. What's that? Called Lutem-Becker syndrome. Is ASD plus MS. Again, it's very uncommon. This is the mitral valve. You see, it's narrowed down. This picture is on echo. Now, what's the natural history of MS? It's a disease of plateaus. Patient has a stage in which patient is asymptomatic, then there's a moderate disease, more symptomatic, and then a more severe disease, more complications. So it's a disease of plateaus. Mild MS, 10 years after initial rheumatic insult. Moderate disease, further 10 years. Severe disease, further 10 years. It means rheumatic fever is usually a disease of children. It generally occurs before the age of 18. After the age of 18, rheumatic fever is uncommon. So it means the children are going to have rheumatic fever and they are going to have symptomatic disease in their 20s and early 30s. So MS generally presents in this age group. Before the 20s, MS clinically generally does not present. Mortality is due to progressive pulmonary congestion, infection, thromboembolism. For our patient, we go for echocardiography to see the valve surface area, any calcification present, what is the atrial size on echo, is there any pulmonary hypertension, any unrecognized lesion which could not be detected on initial assessment. If the patient is symptomatic, we can control the heart rate with beta blockers. Percutaneous valvotomy can be offered for this patient if the patient is symptomatic, because we find the valve is pliable. First heart sound is loud and there is an opening snap. This just indicates this is a pliable valve. Then another case, a 32-year-old lady presented with occasional palpitations and shortness of breath on moderate exertion. You see, it's in the late 20s and early 30s the patient present clinically with symptoms. Physical, she had an irregularly irregular pulse. It means LA is large now. No A wave in JVP. That means patient has, if the A wave is absent in JVP, what does that mean? Why the A wave is produced? Because of the atrial contraction. So if the A wave is absent, atrial is not contracting again, indicating atrial fibrillation. Apex barely palpable. It means the valve is calcified and there is no MR. It's a tight valve. Parasternal if present, palpable P2, pulmonary hypertension. Soft S1 and absent opening snap, it is again a calcified non-pliable valve. Loud P2, pulmonary hypertension. So you can find out what is going on in this patient. The patient has developed pulmonary hypertension. The valve is not pliable. This valve cannot be opened with balloon valvotomy. This valve will need to be replaced. Only mid-diastolic murmur. No late systolic accentuation means atrial fibrillation. A shorter S2 to opening step interval indicates more severe disease. Now, I need your attention here. You have a first heart sound, systole starts. There is a second heart sound, systole ends, diastole starts. When the diastole will start, what will happen? Mitral valve will open. The blood will move from the atrium into the ventricle. So this opening produces a sound which is called opening snap. Now the tighter the MS, it means there is high pressure in the LA. The valve will open very quickly and in the early part of the diastole. So after second heart sound, you hear the opening snap. The tighter the lesion, the earlier it is going to be the opening snap. So the distance between second heart sound and the opening snap, it shortens. That indicates a severer mitral valve disease. That a shorter S2 to opening step interval, this is represented here. This is second heart sound, this is first heart sound, this is opening snap. When it becomes tighter, you see this starts moving towards the second heart sound. This red line starts coming towards this S2. Do you understand this? If you don't understand, tell me, I'll tell you again. First heart sound, the start of systole. Second heart sound, the start of diastole. What happens in diastole? Blood moves from the left atrium into the left ventricle. So it needs the mitral valve to open. And when the mitral valve opens, it produces a sound because the valve chordae are stiff. So it produces a sound which is called opening snap. And remember, this opening snap is heard in a pliable valve. You may not hear when the valve is very calcified. You may not hear an opening snap. So when this opening snap comes, there's a time between second heart sound and opening snap. When the MS will become tight, it means the pressure in left atrium will become more. Left atrium will have a higher pressure than normal. It means the valve will open very quickly and very rapidly or very shortly after the second heart sound. So the opening snap will come closer to the second heart sound. So if the opening snap is closing to the second heart sound, this means this is a tight mitral valve. But clinically, it's very difficult, and in examination, I don't think you are going to have this thing. You just know it theoretically, because practically it is very difficult. Only in patients who've got a slow heart rate, you can pick. Patients with this sort of a situation, when you got tighter valve, the patient tend to have tachycardia, and there is atrial fibrillation. You may not be able to pick it, so you have to slow down the heart with beta blockers or digoxin, and then you appreciate that the S2 is coming closer, OS is coming closer to the S2. But you should remember, if you want to assess the severity, you assess the time between the second heart sound and the opening snap. Clinical presentation is progressive shortness of breath. LA dilatation causes pulmonary congestion, and there is decreased lung compliance. It worsens with exercise, fever, tachycardia, and pregnancy. Anything which causes tachycardia is going to worsen MS. Anything which is there, it's going to cause tachycardia. The MS symptoms will worsen. Increased transmitral pressure leads to left atrial enlargement, atrial fibrillation, and its consequences. What are the consequences of atrial fibrillation? There will be a clot formation inside. Right heart failure symptoms, they come due to pulmonary venous hypertension. Patient may have hemoptysis because of rupture of bronchial vessels because of the elevated pulmonary pressures. So some of the patients may present with hemoptysis. Physical findings, small volume pulse, there may be atrial fibrillation. There is a prominent A wave in JVB, it's absent in atrial fibrillation. This A wave is absent in atrial fibrillation. There may be features of right-sided heart failure in advanced disease, mitral phases, in severe MS. These are seen in pinkish purple patches in fair-colored people. They're not seen in dark-skinned people. They're not visible. You see, this is one. The evaluation, ECG may show atrial fibrillation and changes of left atrial enlargement. Chest X-ray may show LA enlargement and pulmonary congestion, occasionally calcified mitral valve. How do you see LA enlargement on chest X-ray? No cardiomyopathy. The LA is lying behind the heart on chest X-ray. You cannot see. You can see the splay of carina when the trachea divides into the main bronchi. There is a widening of this called splay of the carina. Instead of being normal like this, it's like this. You may see a double shadow of left atrium behind the heart. You may see that there is filling of the pulmonary bay which is visible in the left border of the heart. So it's difficult to pick this on chest X-ray, but I think Dr. Fawad can pick it up. It's difficult for you. Gold standard is echo. It tells us about the mobility of the valve, gradient, and mitral valve area, and any accompanying lesion if it is present. And you see this is LA, this is LV. You see LV cavity, and you see the size of the LA. It's fairly big. Severity of MS. You see if it's from the pressure gradient and the area. If the pressure gradient is less than 5, it's mild, 5 to 10 more. If more than 10, this is severe. Pulmonary artery systolic pressure less than 30, between 30 and 50, and more than 50. Valve area 1.5, 1 to 1.5, and less than 1. So this is how we assess the severity on echo. Management, serial echocardiography, mild MS 3 to 5 years, moderate 1 to 2 years, severe MS yearly. Medication, MS like AS is a mechanical problem, and medical therapy is not useful. You need surgical therapy for correcting MS. Beta blocker, calcium channel blocker, digoxin can be used to control the heart rate. So you avoid tachycardia, because tachycardia worsens the symptoms of MS. anything which causes tachycardia. So anything which can reduce tachycardia is going to help control the symptoms. Diuretics for fluid overload. And then you can go for surgical treatment. Identify patients who benefit from percutaneous valvotomy. Our first case, which was with pliable valves, is a candidate for valvotomy. The second case is for valve replacement. Infective endocarditis prophylaxis. MS is not a very high risk lesion for prophylaxis of endocarditis, but if there's a prosthetic valve in place, this may require infective endocarditis prophylaxis. Simplified indication for mitral valve replacement treatment. Any symptomatic patient with NYHA class 3 or 4 symptoms. Asymptomatic moderately severe MS with pliable valve is suitable for valvotomy. Now this is how valvotomy is done. You can see you place a valve across the mitral valve, you dilate it, and you can see the dilatation now. This is valvotomy. Now what is MR? Backflow of blood from the left ventricle to the left atrium during systole. Mild MR is seen in 80% of normal individuals. So when you do an echo of 100 people, you find some regurgitation in normal people as well. Now it can be an acute MR. Acute MR develops in the settings of endocarditis, acute myocardial infarction. These are two important things. When you develop acute mitral regurgitation, you can also develop in patients who've got prosthetic valve dysfunction or trauma to the chest. That sometimes can result in AR or MR. Chronic mitral regurgitation, myxomatous degeneration, the most important in young adults. The most important reason for MR is myxomatous degeneration, that is mitral valve prolapse syndrome. Ischemic mitral regurgitation, rheumatic heart disease. You see mitral regurgitation as a cause, rheumatic heart disease as a cause of mitral regurgitation is far less common. When you see mitral stenosis, you think of rheumatic fever. When mitral regurgitation, think of myxomatous degeneration, infective endocarditis. Now what happens in MR? It's a pure volume overload situation. There is regurgitation, LA enlargement, LV hypertrophy, and increased contractility. These are the consequences of mitral regurgitation. When the blood goes during systole, the blood from the left ventricle goes into the left atrium. So left atrium is now receiving blood from both sources. It's getting blood from left ventricle, and the blood is coming downstream from the pulmonary arteries. So LA has got very high volume, and this high volume is shifted into the LV as well. So LV enlarges, and there is increased force of contraction. There is progressive LA dilatation with right ventricular dysfunction due to pulmonary hypertension. Progressive LV volume overload lead to dilatation and progressive heart failure. So in mitral stenosis, there is no heart failure. LV is normal. In mitral regurgitation, over time, LV starts failing. So that's the main difference between the two. If the patient develops pulmonary edema in MS, it's a different reason. And if the patient develops pulmonary edema in MR, it's a different reason altogether. In MR, there is LV failure. In MS, there is no LV failure. In MS, it's the failure of blood to move across the mitral valve. So there are two different reasons for pulmonary edema in both conditions. Natural history of MR, compensated phase, 10 to 15 years. That means from the start of the MR, for 10 to 15 years, they may not have symptoms because the heart starts adjusting by increasing its size and getting hypertrophy. So patient does not have symptoms. Patients with asymptomatic severe MR have a 5-year mortality rate, 5% per year mortality rate. Once the patient's ejection fraction becomes less than 60% or patient becomes symptomatic, mortality sharply rises. So the patient can have an abrupt decrease in their life. So mortality increases abruptly. Now, what is this ejection fraction? What is meant by ejection? The fraction of the blood which is ejected during systole out of the end diastolic volume. Normal end diastolic volume is 120 ml? 120 ml. How much is ejected with each stroke volume? It's about 70 ml. 70 ml is. So it turns around 60%. In what happens in MR, the ejection fraction starts increasing. Ejection fraction may go to 70%, 80% for compensation because there is a lot in the LA and LV. When the LV starts becoming weak, the ejection fraction starts dropping and it comes to 60% or less than 60%. It means the patient is going to have symptoms. Normal people have a 60% ejection fraction, they do not have any symptoms, they are normal. But in MR, if the ejection fraction comes to 60%, it means the patient is now compromised because in MR, the ejection fraction is usually more than that. So when they have ejection fraction which comes to the normal value, these patients are at risk of developing heart failure and death increases in these patients. Are you getting it? Mortality is from progressive dyspnea and heart failure. Clinical features of acute MR, dramatic pulmonary edema with shock. Patients present with very acute development of pulmonary edema. Patient is admitted in the hospital for acute myocardial infarction, for example. On the second day, your staff nurse comes, come on doctor, the patient is very sick. You just go and find patient is hypotensive, patient is pale, sweating, very short of breath. You examine, there is tachycardia. You may not find a murmur, but you will find pulmonary edema. So it's the clinical setting which tells you that if the patient had developed MI on a second or third day, patients develop this sort of clinical features, there's a very strong possibility the patient has developed acute MR or maybe it's a ventricular septal defect. Because ventricular septum may also rupture at the same time. So you just be on the guard, the patient may have developed this pulmonary edema. Chronic MR, patient has progressive shortness of breath for a very long time. It remains asymptomatic, but then starts developing this progressive shortness of breath. Patient does not usually present with this sort of acute pulmonary edema, except in the patient develop complications. For example, if they develop an fibrillation, they may have this acute presentation. Otherwise, they have progressive shortness of breath. The pulse is generally good volume. There is ill-sustained apex beat which is displaced down and out. So it's a diagonally displaced apex beat indicating a dilated heart. There may be systolic thrill. There may be a parasternal lift if the patient has developed pulmonary hypertension. Auscultation may indicate a soft first heart sound. In fact, a first heart sound may not be audible. It may be engulfed in the murmur. So you have a soft first heart sound. There may be a pan-systolic murmur which may radiate to axilla or which may radiate even to the back. You may have third heart sound because of the volume overload. In chronic MR, the intensity of murmur does correlate with the severity. With acute, I said you may not even hear a murmur. Imaging studies, ECG may show LA enlargement, atrial fibrillation, LV hypertrophy. In cases of severe MR, with mild MR, you may not have any changes in the ECG. Chest X-ray may show LA enlargement, central pulmonary artery enlargement. Echo shows LA is enlarged, LV is enlarged, ejection fraction is increased. It can also tell us about the structure of the valve as well. Transesophageal echo, if transthoracic echo is inconclusive. Acute MR, if developed in myocardial infarction, cardiac catheterization, and thrombolytics. Most other cases of mitral regurgitation is just after load reduction. You just cause peripheral vasodilatation. When there is peripheral vasodilatation, the blood will easily run off the aorta. So the regurgitation will be reduced. So in patients who got MR, you need only after load reduction. Diuretics and nitrates. Nitroprusside, even in the setting of a normal blood pressure, nitroprusside can be used because it causes arterial vasodilatation. So when there is contraction of the LV, the blood goes into the LA. And if we decrease the peripheral vascular resistance, the blood will also easily move forward as well. Emergency surgery, valve replacement. Do not attempt to alleviate tachycardia with beta blockers. If you slow down the heart, the blood pressure will drop further. So don't use beta blocker. Mild to moderate tachycardia is beneficial in these patients because it allows less time for the heart to have backfill, which lowers the regurgitation volume. Chronic MR, vasodilators such as hydralazine, ACE inhibitors, ARBs. Rate control with beta blockers, calcium channel blockers, or digoxin, preferably with digoxin. Anticoagulation in atrial fibrillation and flutter. Diuretics for fluid overload. So this is for chronic MR. Serial echo every 2 to 3 years. In moderate, it's 1 to 2 years. In severe, 6 to 12 months. Infective endocarditis prophylaxis. You see, MR is a high-risk lesion for infective endocarditis. MS and ASD are low-risk lesions for infective endocarditis in the native valve. If you have prosthetic valve, the chances of having endocarditis are more. So in mitral regurgitation, even with a native valve, the chances of endocarditis are more. So remember, anywhere, in any lesion, when there is a high pressure gradient across that lesion, it's a high risk for endocarditis. For example, a VSD is a high risk as compared to an ASD. AR is, or AS is high risk as compared to the MS. Or MR is high risk as compared to the MS. So when the pressure gradient is high, the risk is more. So if patient has any symptoms, replacement. If the patient is asymptomatic, EF is less than 60, or if the patient has new onset atrial fibrillation, we can go for replacement.